Hello, everyone. Um, so this lecture will be on the GI tract or disorders of the GI system, and it includes 4 chapters. Uh, Chapter 49 focused on the GERD disease, gastroesophageal reflux disease. Chapter 50, concepts of care for patients with stomach disorders, which will focus on gastritis and peptic ulcer disease, PUD, and gastric cancer. Chapter 51 will cover the content on intestinal obstruction and colorectal cancer, CRC. And the last chapter, 54, which will cover the content or concepts of care for patients with biliary system and pancreas. And the focus will be on one disease, which is cholecystitis and cholecystectomy, the surgical excision or removal of the gallbladder. So let me share the screen with you. So these are the 4 chapters that will be covered in this session or this lecture. So the first disease, which is a GERD disease, which usually is very common and results when the LES, and that's from pathophysiology, which is lower esophageal sphincter, which is another name for the LES, which is the cardiac sphincter, which is the sphincter between the last segment of the esophagus and the stomach, so that the connection or the sphincter between the esophagus and the stomach, which is the LES or cardiac sphincter, lower esophageal sphincter or the cardiac sphincter. So the GERD will result from, or when the LES is weak, that sphincter is weak, by increased pressure or decreased tone, which is the strength of the smooth muscle. Lots of or too many risk factors. The increased pressure would result from like hiatal hernia, obesity, collagen vascular disease, pregnancy. The decreased tone, so we said that GERD disease either result from increased pressure or decreased tone at the LES or cardiac sphincter. So the decreased tone would result from alcohol, caffeine, nicotine, chocolate, fatty food. So it's a very common disease. And also it can be common cause of hoarseness of the voice and chronic cough, and may exacerbate to mimic like asthma, like patients like we have as if we have asthma. The symptoms that patients will present with an uncomfortable hot and burning sensation beneath the sternum. And these symptoms usually worsen after, become like worse after meals or reclining. And when the patients or people wear tight clothes. So we have a case study, and of course, for the sake of time, I don't, want to waste time reading from the slide or the case study. So you can read it in your own. I'm just gonna head to the questions, or I can just highlight certain things from the case study. Or before we go to the case study, we can talk about the treatments. The treatment will start with the lifestyle modifications, like elevate the head of bed, avoid bedtime snacks, or avoid the triggering foods like fatty food, chocolate, mint, alcohol, cigarettes, and NSAIDs. And in addition to also promote weight loss. Drugs or medications can be prescribed to treat GERD will be antacids, histamine 2, H2 receptor antagonists or blockers, PPIs, and if symptomatic relief is achieved, so if these symptoms relief is achieved with the use of the H2 blocker or the PPI, then discontinuation of the treatment after 8 to 12 weeks may be successful. And if the disease is refractory to medical therapy, then we can consider the evaluation of niacin fundoplication or hiatal hernia repair, and we'll get to these surgical interventions later on. And they are well described in the other set of PowerPoint slides as well. So going to the case study. So a patient 52 years old, construction worker, and the patient had complaints of persistent cough for the past 4 months. So there was sources of stress. Patient lost his mother and developed severe depression. And noticed a 20-pound weight gain over this period. So there are few risk factors that precipitated that patient to develop GERD disease, given or considering the risk factors I mentioned earlier. So the first question, which of the following statements describes the likely cause of this chronic cough? And we said that the patients with GERD disease, they tend to develop that chronic cough. So the answer would be that the patient had developed GERD disease, gastroesophageal reflux disease. Although the most common cause of chronic cough in adults is what is called the post-nasal drip syndrome. The patient's cough is present only in the recumbent position and at nighttime. So this sign, as well as the fact that he has recently gained considerable amount of weight, which was 20 pounds, which point towards the correct diagnosis of GERD disease. All of the other answers, potential causes, can be also be considered as potential causes of chronic cough among adults. The history and examination gives some clues that point towards the GERD disease, like constant clearing of the throat, worse during recumbence position, normal nasal mucosa, and worse after meals. And give some others that would make the alternative diagnosis less likely. So next question, next question. Which of the following therapies would be most beneficial in alleviating patients' symptoms? And B will be is the correct answer. So because the symptoms are due to GERD disease, they should be treated with a PPI as initial therapy. Although the weight loss and exercise may be beneficial in relieving the GERD disease or symptoms of GERD, they should be considered additional therapies and not curative. Antibiotics are not necessary since the patient doesn't show signs and symptoms of bacterial or fungal infection. The use of cough suppressant and expectorants would temporarily improve the cough, but would do nothing to address the underlying problem or the underlying disorder. Inhaled bronchodilators like beta-2 agonists play no role or function in the treatment of GERD disease, unless the patient was to develop pneumonitis and dyspnea. So the next case study would be on GI bleeding. So the second case study, which also covers the GERD disease, gastroesophageal reflux disease. This patient has also manifestations of the disease. He constantly feels like he has a metallic taste in his mouth, and not relieve the symptoms. So this is over for the past 6 years. These symptoms are not relieved by the omeprazole, and he started with ranitidine, or ranitidine, which is H2 block, H2 antagonist. So the review of systems: sore throat, hoarseness of the voice, proctation, no shortness of breath, and no exertional chest pain. The physical exam shows that patient is obese, and lungs clear to auscultation, no wheezes. Now, as we review the patient's meds or the meds he's taken, which is the ranitidine, which is the H2 blocker or antagonist, it blocks 2/3 of the acids. So the histamine stimulation is one of the 3 stimulants to parietal cells, the parietal cells in the stomach, which produces the HCl or these secretions. And histamine, we know that the histamine function also to potentiate the gastrin hormone and acetylcholine. So the antihistamine, which is H2 histamine, not the H1 receptor, the H2 receptor in the stomach, will be blocked, like with ranitidine, cimetidine, famotidine. These drugs are H2 blockers to treat stomach ulcers or GERD disease. So the first question is asking about the most likely diagnosis given the patient's scenario, which is refractory GERD disease, a GERD disease that is refractory to the traditional treatment. So the patient's symptoms are classic for GERD, which is sore throat, metallic taste, and in addition to the hoarseness, chronic cough, wheezing. So this patient also has been an optimal PPI drug or therapy without any improvement, and therefore can be labeled as refractory GERD disease, which is the disease that is refractory to the traditional or usual treatment. The PUD, when we say peptic ulcer disease or PUD, it gives provides abdominal pain that may or may not be worsened with eating. The duodenal ulcer, the GU or duodenal ulcer and gastric ulcer, they are both two different types of PUD, peptic ulcer disease. So when we say PUD, it includes both duodenal ulcer, which affects the ulcer that affects the duodenum, small intestine, and gastric as well. The pain of the duodenal ulcer is more often improved with eating. So this is the difference with pattern of these two types of PUD, stomach or gastric ulcer versus the duodenal ulcer. The duodenal ulcer provides or gives the abdominal pain that may or may not be worsened with eating. However, the pain of the duodenal ulcer is more often improved with eating. So so we said that the difference with the pattern of pain in relation to food is not sufficient by itself to distinguish between duodenal ulcer and gastric ulcer. There are other diagnostic tools that can be used to differentiate. So the patient is advised to continue with his PPI medications for 3 more months. In addition, also was counseled to also make therapeutic lifestyle changes. So patients with on a PPI, they have also high gastrin level, the gastrin hormone level, because the lower the acidity in the stomach or the GI tract, low acid, it will result in high gastrin hormone. Second question is, which of the following is most likely to improve the patient's symptoms? So the answer to this is the weight loss. All lifestyle modifications, or out of all of these modifications, the weight loss and elevation of the head of bed reduce these two modifications, lifestyle modifications, weight loss, elevating the head of bed, will reduce the symptoms of the GERD disease. Dietary modifications help, but such modifications increase non-compliance to changes because of restriction of what is called enjoyable food. People don't like to, abstain or stop taking these enjoyable foods. So that's why the non-compliance would be a problem and challenge for the patients with GERD disease. So the alarming symptoms in GERD disease are dysphagia, weight loss, anemia, blood in the stool, and the long-term side effect of the PPI therapy. If they keep taking these PPI drugs long-term all the time, for years, that could result in side effects like osteoporosis, increased risk for C. diff infection, or CAP, community acquired pneumonia. So, so the symptoms continue despite taking these PPIs and making lifestyle changes. Examination findings are unchanged, and the patient expressed concern again about taking omeprazole for so long. So the most accurate test for the GERD disease is the 24-hour pH. Next question is, what is the best next step in the management of this patient? And the answer for this question is the esophageal manometry. So the patient clearly has the refractory GERD despite optimal medical therapy. And in addition, no longer wishes to take medications. So the patient needs surgical or endoscopic procedure to tighten his lower esophageal sphincter, the LES. So the LES or the cardiac sphincter should be tightened surgically. And the best next step is in the management is to refer the patient for esophageal manometry as part of the preoperative workup before the anti-reflux surgery, before the surgical procedure. So the anti-reflux surgery, when we say anti-reflux surgery, is the intervention or the optimal surgical intervention when the medical treatment failed to treat the patient's GERD disease. Like so these are the scenarios in which that the anti-reflux surgery would be recommended. Failed optimal medical treatment, the non-compliance or refusal to take lifelong medications, or severe esophagitis, which is the infection or inflammation of the esophagus. When it's severe, then the anti-reflux surgery would be prescribed or recommended. Now, number 4, which with following is the mechanism of the GERD disease. And we, in previous slides, we did say that the disease results from the incomplete relaxation of the LES, either pressure increase or low increased tone. And we have examples of when the pressure will be increased and which factors would decrease or lower the tone of the sphincter. So it's an incomplete relaxation of the lower esophageal sphincter, the LES, which is the cardiac sphincter. And the GERD doesn't result from the H. pylori. Number 5. So before we go into the niacin fundoplication procedure, that's another surgical procedure. This surgical procedure called niacin fundoplication, it reduces symptoms in about 85 to 90% of patients. It will tighten the sphincter by wrapping the stomach around the lower esophagus. It's like a wrap or collar around the esophagus. old fundoplication. So complications associated with this procedure. So which of the following is a complication of niacin fundoplication? The gas bloat syndrome is the inability to eliminate swallowed air or gas from carbonated beverages or food by belching. Treatment is with the prescription or with, when the patient takes simethicone, which is an anti-gas, so that treats the gastric or intestinal gas being retained or collected in the GI tract. Simethicone would take care of that. The next disease is the peptic ulcer disease, PUD. Or gastric, first gastritis, and then we'll go over the peptic ulcer disease. So gastritis or chronic gastritis or it's called atrophic gastritis. We have like two different types, type A and type B. A, which is fungal gastritis, type B, which is antral gastritis. The fungal one, which is type A, most likely is going to result from as an autoimmune disease. Like patients with pernicious anemia will be affected by type A. Type B, antral, which pertains to the antrum of the stomach in terms of the structure of the stomach antrum. Type B, and that's usually would result from the H. pylori or the excessive use of NSAIDs or the cytomegalovirus or CMV. And patients will complain of pain, gastric pain, nausea, vomiting, anorexia, upper GI bleeding, which is manifested as coffee ground emesis, which is vomiting, or hematoemesis, which is vomiting with blood. So will be diagnosed with upper endoscopy, and the treatment depend on the etiology. The treatment for H. pylori with PPI and 2 antibiotics, like amoxicillin and clarithromycin. If drug-induced, then patient should stop the offending agents like the, usually it's the NSAIDs. And then we add the PPI as a treatment. After that, we stop the precipitating factor, which is the NSAIDs, and then we add the PPI. If the cause is pernicious anemia, then we'll treat it with the vitamin B12 replacement, which is a supplement, which is a cyanocobalamin vitamin B12 replacement. If that's stress ulcer, which is especially result in when the patient is admitted in the ICU setting, then the patient should be prophylactically treated with IV PPI. So that's the chronic gastritis. For the gastric ulcer, the H. pylori is usually found in about 70% of gastric ulcer patients, or patients with gastric ulcer. The 70% of them, they will have H. pylori infection. In about 10% will result or have the gastric ulcer due to a cancer or malignancy, like gastric cancer. The patient will complain of burning pain in the mid epigastrium or mid epigastric pain. It will be worse with food intake. And if the ulcer will erode the artery, that can cause hemorrhage in the stomach and peritonitis. And we know that the classic sign of peritonitis as the board-like rigid abdomen. And you will find also, as you test the patient for guaiac test, guaiac test means the fecal occult blood test. That's always will be positive. So the fecal occult blood test, the other name is guaiac test, Guaiac. Guaiac test is positive. The diagnosis of the gastric ulcer, usually it's done by the endoscopy with a biopsy taken to confirm or rule out malignancy. And the treatment will be with the PPI, proton pump inhibitors, and with antibiotics if that's H. pylori. And we know that H. pylori should be treated with 3 different types of antibiotics. Now, the duodenal ulcer, the DU or duodenal ulcer, the H. pylori is found in about 90% of patients with the duodenal ulcer. Usually the high risk or the highest 2 risk factors are smoking and excessive alcohol intake. Patient will complain of manifestations, burning, epigastric pain, about 1 to 3 hours postprandial after meals. And usually it's relieved by food and with antacids. And typically the patient will be awakened from severe pain at night. And in addition to that, they will have melena, which is blood in the stool, bloody stool, melena, M-E-L-E-N-A. Endoscopy at upper GI series of endoscopies treat the diagnosis with the endoscopy. And the treatment would be very similar to the patients with gastric ulcer. Patient may have or develop some complications from this duodenal ulcer, like upper GI bleed or perforation. And with perforation, the treatment usually it's an emergency surgery to fix the perforation. And when there is a perforation, the patient will experience a change in pain pattern that is different from and not similar to the previous experiences of pain the patient had due to this disease when there is perforation. Now, the case study patient saying that my stool is black, which is, we said, melena, that's when there is a blood next to the stool or bloody stool. The patient is hypotensive, tachycardiac, which is consistent with the blood loss or fluid loss, which in this case, that's let's see, gastric ulcer and bleeding, peptic ulcer disease, and there's bleeding. The That's internal. So the internal bleeding will be indicated with the hypotension and tachycardia. So in addition to also the melena, which is the bleeding in the stool. So the history or past medical history, so the aortic stenosis, hypertension, former tobacco smoker, hyperlipidemia, patient take the statin and nifedipine. And the first question, what is the most important first step to take with this patient? So the first thing, given the patient's hypotension and tachycardia, it's a must that we have to replace fluid. So fluid resuscitation is by far the most important thing you can do for for a patient or a person with a GI tract bleeding. First thing, fluid replacement. So it is far more important to restore a perfusion pressure than to look for the precise etiology of the disease or the bleeding, or what is that the bleeding is coming from, or how to diagnose, or we have to treat and replace the fluid loss so we can prevent the hypovolemic shock. The tachycardia, because patient is the tachycardia. So the tachycardia at rest or systolic blood pressure, which is less than 100, the both indicates the 30% blood loss, blood volume loss. So when you see for an average sized person, this is like 1.2 up to 2 liters of fluid volume loss. And the orthostasis implies the loss of about 15 to 20% of blood loss. And the patient's blood pressure is 96 over 56, and the pulse is 108. Both imply that more volume has been lost than would occur with more orthostasis. So when the intravascular volume is low, in this case, patient has significant loss of blood volume. So there should be an increase in heart rate and vasoconstriction of peripheral vessels to fully correct the blood pressure. So that was a compensatory mechanism, tachycardia, due to the blood loss. Now, when we see orthostasis, we have to check the blood pressure and pulse when the patient is laying down, then sitting up or standing. You can do it either like 3 positions or at 2 different positions. Sitting, standing, lying, standing. So whatever possible. Sometimes it's very difficult, for patients who are, to stand up, and so we can do lying, sitting, for example. So when there is an increase in pulse rate over more than 10 beats per minute, or when there is a decrease in systolic blood pressure more than 20 millimeters HD. And we can say orthostasis when there is about 15 to 20% volume loss. Systolic less than 100, or pulse rate is over 100. These two things, with the systolic less than 100 or pulse higher than 100, that indicate that there is about 30% blood volume lost. So this question 2, what is the information process that detect decreased firing of carotid and aortic baroreceptors. So medulla oblongata, this is from the pathophysiology. The medulla receives the information from the stretch of the mechanoreceptors of the carotid artery, atria, and aortic arch. Decreased pressure and peripheral pressure or mechanoreceptors result in decreased firing. The medulla will respond with a peripheral vasoconstriction and tachycardia. The norepi will stimulate the alpha-1 receptors in the arterioles, causing the vasoconstriction. So this is the compensation. This compensation is incomplete when changing position if there is more than 15 to 20% blood volume loss. So this compensation is incomplete when there is significant amount of fluid or volume has been lost. So the initial orders, as you see, that's normal or lactate, bolus, CBC, PT, PTT, Chem 20, EKG, pantoprazole IV, and GI consultation. So a report came back with these lab values. So if the PT or APTT, which is activated partial thromboplastin time or prothrombin time PT, both elevated, what is the best way to correct it? So that will be fresh frozen plasma. The fastest way to correct the coagulopathy is with fresh frozen plasma. So anytime patient has a problem with coagulation or bleeding, then that will be corrected with fresh frozen plasma. The vitamin K needs at least 12 to 24 hours to work in order to generate clotting factors. And if there is a liver insufficiency, this explains also why patients with liver cirrhosis or with end-stage liver disease, they receive fresh frozen plasma because they have the liver. One of the functions of the liver is to produce clotting factors. So they need, the clotting factors. So the best way is to replenish this is to give them fresh frozen plasma. So if there is a liver insufficiency, then the fresh frozen plasma would be the treatment. The cryoprecipitate cryoprecipitate, which is the condensation of clotting factors from pooled multiple donors. And that would be best when you need like enormous, large amounts of clotting factors, and the fresh frozen plasma is not enough, or the volume of the fresh frozen plasma required to provide that amount of clotting factors would be too great. So which of the following is in highest concentration in the cryoprecipitate? The fibrinogen and von Willebrand factor. So the precipitate is especially high in fibrinogen, von Willebrand factor, BWF, and factor 8. And we know factor 8 is required when the patient has a hemophilia. So the reason we never use cryoprecipitate first. For anyone is that we use demopressin acetate, which is the anti-synthetic anti-ADH hormone, GDAVP, demopressin acetate, which is the synthetic ADH hormone for von Willebrand factor, and recombinant factor 8, that will be for hemophilia. So factor 8 will be for hemophilia. So cryoprecipitate is a pooled product, and pooled products, they transmit more viruses. So the repeat blood pressure now, it's 100/64, and the patient's pulse is 102. Now, why does the BUN rise in pre-renal azotemia? And that's because of, so C is the correct answer. The ADH hormone would increase the urea absorption at the collecting ducts of the kidneys, renal collecting ducts. So when the ADH hormone increases the permeability of the collecting duct to water, it also stimulates the urea transporters that increase urea reabsorption. And this helps maintain the high osmolarity of the renal medulla so that water can be reabsorbed. So the ADH hormone stimulates, again, the urea transporter 1 and the collecting duct of the kidneys, so they can absorb more urea. So more ADH hormone, which means more urea reabsorbed. And blood in the upper GI tract increases the BUN level. Why therapy has a definite benefit in acute GI bleeding, upper GI bleeding. Now, which therapy has a definite, so the PPI, proton pump inhibitors, they do have a benefit in stopping and controlling acute upper GI tract bleeding. This has never been shown with the H2 blockers or even sucralfate. The nasogastric or the NG tube has extremely little benefit. So there is no therapeutic intervention with the NG tube. And the saline or isosaline lavage is useless. And we need to know the difference between lavage and gavage. When we say lavage, means the cleaning of the stomach, the washing of the stomach, like during the poisoning, or to clear the stomach content. That's called lavage. You inject or you instill with the NG tube, and then you suction. Well, the gavage means when you have a patient on with the NG tube or PEG tube on feeding. The feeding is the gavage, and then the lavage is the washing or the clearing the stomach from the content or washing the stomach off, like in the poison, like after acetaminophen, for example, poisoning, for example, or intoxication or overdose. and you want to wash the stomach right from the drug, then that's called lavage. Lavage. Gavage starts with G. Gavage, that's the feeding via even via the NG tube or the PEG tube. Question number 7. What mechanism explains the drop in the hematocrit concentration from 32 to 29 in this patient? So the dilution from dehydration, more fluid administered, dilution. So it is expected that patients will have a decrease of 3 to 4 points of the hematocrit concentration just from receiving the hydration of fluids. So to differentiate the melena or the black stool from the the upper GI from the lower GI. So the upper GI tract source or the upper GI tract, the bleeding will have that the stool is called the melena, or the stool is black stool that is upper GI bleeding, and that's from the oxygenation or deoxygenation of the hemoglobin. Lower GI bleeding is more fresh blood, not black stool or melena. Melena is always, or black stool is always the upper GI bleeding. So number 8, which of the following is the definite benefit of the NG tube? So it can help determine or assist us to determine the source of bleeding. The NG tube placement is, in terms of therapy, it's useless, but for diagnosing, it has the benefit that it can determine the source of the bleeding. So the patient's CBC after 2 hours of hydration shows that the hematocrit is 23% and the platelet is 145,000. And we know that the platelet count should be between 140 up to 440,000. So the NG tube, also we can mention something about the NG tube, is that the problem with the NG tube, besides its discomfort during the insertion, is that the negative lavage will miss about 30% of bleeding, especially if it is in the duodenum. And red blood, so the red blood from the NG tube indicates an upper GI tract source. So only the use of the NG tube definitively excludes an upper GI tract source. If you see bile in the aspirate, as you aspirate the NG tube and find bile. So only the use of the NG tube definitely excludes an upper GI tract source if you see a bile in the aspirate. So 9, what would be the likely cause of death in patients with GI tract bleeding? And the answer is the myocardial infarction. Decreased oxygen carrying capacity to the myocardium leads to ischemia. The myocytes in the heart cannot distinguish between hypoxia, coronary stenosis, or anemia. Ultimately, with severe bleeding and anemia, the patient will infarct his, so there will be like, myocardial infarction. So the patient has an aortic stenosis, so that implies a 50 to 70% chance a patient has coronary disease. So the older person, older adult, we need to keep the hematocrit concentration over 25% up to 30%. Young, healthy person can easily tolerate the hematocrit level of 20 to 25% until the bone marrow recovers in about 2 to 3 weeks. The order is to transfuse with packed RBCs and CBC with an upper endoscopy. Now, the hematocrit should increase by about 3 points for each unit of packed red blood cells given or administered. Question number 10, at what platelet count should the patient receive platelet transfusion? Answer is C, which is less than 50,000. So we'll administer platelets will be administered when the level drops below 50,000. When patients are bleeding or going to for surgery. If patient is not bleeding, there is no need to keep the patient, to keep the count that high. So the death from the GI tract bleeding, that's usually would result from inadequate fluid resuscitation. So the upper GI or endoscopy was performed and no varices were found, but there is an ulcer in the duodenum with some visible bleeding. So what would be done differently if there were esophageal varices? And remember this esophageal varices, if you recall from pathophysiology, these are the small tiny blood vessels in the esophagus that will become distended and fragile, very easily ruptured. And that's due to, as a complication from the hepatic encephalopathy, from the liver cirrhosis or what is called the end-stage liver disease. So liver cirrhosis will result in complication called esophageal varices. So what would be done differently if there were esophageal varices? In other words, how would you treat esophageal varices, which takes us to the hepatic or liver cirrhosis and the treatment of the esophageal varices in patients with liver cirrhosis. So the treatment would be the octreotide and banding. Remember, these are the outpouching or the swelling and the edema and the um, enlargement of the delicate and fragile blood vessels in the esophagus, so uneasily ruptured. So the treatment would be octreotide, which is sandostatin medication. It has many indications, many reasons or indications for its use, in addition to the banding procedure. So octreotide, it will decrease the um, acute varices bleeding. The banding will stop the bleeding from these blood vessels in the esophagus. The sclerotherapy is only done if the banding cannot be performed for a technical reason. And we will cover all of these, modalities or treatment for patients with liver cirrhosis in adult health 3 extensively will be covered in adult health 3. So I'm going to just to skip this because we'll also cover the TIPS surgery, the Blakemore single stake in Blakemore tube and its use, the interventions, the post insertion complications, nursing care, all of these. So this is a very important question, significant, very important question. The content very intensive, but will be covered in adult health 3. So this is the tube called single stake Blakemore tube that will treat the esophageal varices. Case study number 4, which focuses on the peptic ulcer disease. So the most common cause of epigastric pain for this patient will be the non-ulcer, which is functional dyspepsia. About 50 to 90% of epigastric pain is functional dyspepsia, and no etiology is ever found. So the non-ulcer dyspepsia is like a tension headache, for example. So it is by far the most common cause of pain, and nothing of the mechanism is clear. And the ulcers, they make up to like only 10 to 15% of the epigastric pain. So the patient will be on omeprazole only. The alarm symptoms, which indicates the urgent endoscopy, would be weight loss, blood in stool or anemia, and dysphagia. So review of systems, no weight loss, no blood in stool, no dysphagia. The absence of all the 3 alarm symptoms. So which is reliably associated with tenderness on examination. The which is B, pancreatitis. Only pancreatitis is routinely associated with epigastric tenderness. Ulcer disease is tender only in about 10% of the time. So endoscopy, when we say endoscopy, it's required when endoscopy or the scope or endoscopy um, is a key or required for epigastric pain, when there's bleeding, patient's age 45 up to 55, symptoms not relieved with PPIs. So the upper endoscopy shows a large gastric ulcer. So the biopsy is obtained to rule out the H. pylori or to find if there is H. pylori or not. And the rapid urea test is positive for H. pylori. So there is a biopsy and there is a rapid urea test as well. Two different diagnostic tests. So number 3, how is gastric ulcer managed differently than a duodenal ulcer? So the answer will be B, repeat the endoscopy and do a biopsy in 48 weeks. The gastric ulcer is associated with cancer. That's kind of risk factor for gastric cancer, gastric ulcer. So the duodenal ulcer is not associated with cancer. So the endoscopy will be repeated, repeated the endoscopy or the scope for the gastric ulcer to determine or to be sure it has resolved and there is no cancer. And the indication for endoscopy in this patient was the failure of the anti-secretory therapy with the PPI, the failure of the PPI as medication to stop the secretions in the GI tract. So the orders is to continue the PPI and start amoxicillin and clarithromycin, which indicates the H. pylori is positive. So there is a 4% association or correlation between cancer and gastric ulcer. So gastric ulcer can result in about 4% or being accounted for 4% as a risk factor that would lead to cancer, gastric cancer. The duodenal ulcer, 0%. There is no any association, there is no any correlation. Number 4, how does the H. pylori survive in the acid of the stomach? Because the treatment of the H. pylori requires a long-term treatment sometimes. So that's because of the urease makes ammonia to neutralize acid. The H. pylori has urease. The urease makes ammonia out of urea. The ammonia, which is the NH3, binds with the acid, which is the H plus, and turns into ammonium, which is NH4. And this is how acid is neutralized. And that's the fundamental basic kind of concept about ulcers and how the ulcers would develop. So the H. helicobacter or the H. pylori neutralizes acid with ammonia. So for which of the following is treatment for H. pylori helicobacter not indicated when found? So that's the GERD. The Helicobacter H. pylori does not cause GERD. It is associated with all the others, and is largely the causative organism. Case study number 5, which is also a peptic ulcer disease. Patient's past history reveals for approximately 20 years has been experiencing epigastric pain that lasts for 2 to 3 weeks during aspirin. I'm sorry, during spring and autumn. So the physical exam revealed the fullness in the epigastric area with visible peristalsis. So most likely diagnoses for this patient would be gastric outlet obstruction. So in a patient who has or who's known to have had symptoms of peptic ulcer disease for many years and presents with nausea and vomiting, we will or we have to consider gastric outlet obstruction. And the obstruction can be the result of the exacerbation of the ulcer and the subsequent edema of that ulcer. It can be secondary or result to scar tissue formation. And these patients typically they describe the sensation of the epigastric fullness and demonstrate visible peristalses going from the left to the right. The history of pain relief by taking the antacid also make us think of that diagnosis of previous peptic ulcer disease. The patient with the umbilical hernia will have a mass in the region of the umbilicus or around the umbilicus. Patients with acute cholecystitis, which will be covered later on in this session, patients with acute cholecystitis usually they are presented with the sudden onset of pain radiating to the back with fever and chills. And the volvulus of the sigmoid colon presents with constipation, abdominal distension. But vomiting will be present, but will be a late feature. The small bowel obstruction also will be covered during the session, would be associated with a history of colicky abdominal pain, nausea, and vomiting. And additionally, we can say that the patients with small bowel obstruction usually they have hyperactive, high-pitched bowel sounds on examination. So that's some of the differences in terms of signs and symptoms, how to compare between these diagnoses, the GI diagnoses. Which of the following metabolic abnormalities are typically found in the above patient? So hypokalemia. With persistent vomiting, the patient becomes dehydrated and hypovolemic. Loss of hydrogen ion, potassium, and chloride in the vomited, which is the vomitus or the vomited gastric contents leads to alkalosis, hypokalemia, and hypochloremia, not hyperchloremia, hypochloremia. In response to the hypovolemia, the adrenocortical and renal mechanisms are stimulated to conserve sodium at the expense of potassium and hydrogen ions. So exertion of or removal or the output or the excretion of potassium in the urine, it will further aggravate the hypokalemia. So the more potassium being released or excreted in the urine, more potassium, so that will aggravate the hypokalemia. And the kidneys then compensate by exchanging the hydrogen ion for potassium, which will perpetuate that metabolic alkalosis. Next is the case study of upper GI bleeding. Blood pressure. So patient had a hemato-MSS. Vomited blood means hemato-MSS. Blood pressure 114/77. Supine and then standing. Significant reduction in systolic and diastolic, more than 20 points. In addition to tachycardia, 121 pulse. Past medical history, arthritis of left knee and right shoulder, meds, naproxen, twice daily and aspirin. In the social history, heavy smoker. In addition to alcohol intake. Review of systems, physical examination, and the initial orders. So I'm just going really fast, so because you can read it your own. I'm just going to answer the questions and give you an explanation and rationale for the questions, and then have your time to go over the scenario and the other components of the scenario, like vital signs and review of systems and the physical exam and results and initial orders. So I'm going to go right to zero in and focus on the questions. So what is the best next step in the management of this patient, given this scenario? So first of all, the most common cause of death in gastrointestinal bleeding, we said it's myocardial ischemia. So that's why we always have to make sure that we request an EKG, given this risk or complication. Because severe anemia from that bleeding, significant loss of blood, that will result in severe anemia, it will lead to ischemia and ischemic changes. And myocardial ischemia that would be expected, and patients, and that could result in, you know, death of the patient. So the answer would be the IV. I'm sorry, the IV normal saline bolus, and we did similar question in the previous scenarios. We said that the most critical part of the initial evaluation of any patient who present with upper GI bleeding is to assess the fluid or blood volume, the replacement, and the airway. Assess blood volume replacement and the airway. So on this patient has no evidence of breathing difficulty, but does demonstrate significant circulatory compromise in the form of hemorrhagic shock. So you can tell about the internal bleeding, like upper GI bleeding. That's one of the principles, is to assess the patient's or take the patient's blood pressure at least at two different positions to see if there is any orthostatic hypotension, because the orthostatic hypotension is one of the indications of the active bleeding, especially internally in the patients with GI bleeding. So that's the significance of the orthostatic blood pressure taken at least at two different positions. So the evidence of this tachycardia, hypotension, and orthostatic hypotension so that's the evidence for this, for that's the patient has an active GI bleeding, tachycardia, hypotension, orthostatic hypotension. So the patient should immediately have two large bore IV lines placed and receive normal saline boluses, and that should be followed by the packed RBCs, blood transfusion. So number two, what is the demarcation point between upper and lower GI bleeding? Which is, this is from the pathophysiology, which is called the ligament of treaties or treats. So upper GI bleeding is defined as any bleeding that occurs proximal to the ligament of treats, which delineates the crossover point between the duodenum and the jejunum. So that's pure pathophysiology, question in terms of that, the demarcation between upper and lower GI, which is the ligament of treats. So these are the results, and then we have some orders and the results of the orders. So the question here is, and we have a very similar question previously. It says here, what is the mechanism of high BUN to creatinine ratio and prerenal azotemia from decreased renal perfusion? The ADH hormone, I think we had a similar question to this, which is about the ADH hormone, that the ADH hormone increases urea reabsorption at the collecting duct. So that would increase the water reabsorption from the collecting duct and into the renal interstitium. And that would dilute and the concentrating ability of the kidney. And also we talk about the urea transporter 1, that the ADH also puts the urea transporter 1 directly into the collecting duct and cause the direct urea absorption in the collecting duct. There was a similar question prior to this. So who would receive packed RBCs? Packed RBC should be given to older adults with hematocrit less than 30%, or young people with hematocrit less than 25%. So hematocrit less than 30% plus older adult, packed RBCs. Hematocrit less than 25% plus being a young adult, then packed RBCs. Platelets less than 50,000 with active bleeding, patient should be transfused with blood as well, with fresh frozen plasma. Platelets less than 50% with active bleeding, patient should also be transfused with fresh frozen plasma. Patient with a INR over 1 higher or more than 1.5, then patient should receive fresh frozen plasma and vitamin K. INR over 1.5, patient should receive fresh frozen plasma and vitamin K. Question 4. The next step in the management would be the IV omeprazole. The IV omeprazole, which is a PPI, that is the best next step in the management and should be initiated in all patients with suspected upper GI bleeding before we recommend the endoscopy or before endoscopy is recommended as part of the initial set of orders. Also, the PPI therapy has revealed or has been shown to reduce rebleeding of the GI tract or in the GI tract and promote healing of the stomach lining caused by the increased pH. So the PPI has shown to reduce the rebleeding. It will decrease the severity of the lesions and promote healing of the stomach lining caused by the increased pH. It has too many benefits, in addition to also promote the clot stabilization, so it will promote the outcomes, promote the clot stabilization, so it will improve the outcomes. The endoscopy should be done concurrently, but the PPI are tried first. The angiography is only done or recommended for failed endoscopic hemostatic control, because to control the hemostatic control means to stop the bleeding. So the angiography is only for failed endoscopic hemostatic control with endoscopy, and the bleeding is massive. And the bleeding scans are only for lower GI bleed or GI bleeding. And the nuclear bleeding scans are non-specific. Ranitidine doesn't raise the stomach pH above 4. So it's not nearly as useful in upper GI bleeding as the PPI. So the H2 blockers like ranitidine or cimetidine or famotidine, they do not raise stomach pH adequately. So the next step, number 5, in the management would be the endoscopy. After adequate volume resuscitation, correcting for anemia and coagulopathy, the best step or next step is upper endoscopy, known as EGD, esophageal gastroduodenoscopy. Esophageal gastroduodenoscopy, EGD. The EGD, which is the endoscopy here, allows for diagnosis and intervention of the bleeding site. Diagnose and intervention. So we can diagnose and do the intervention for the bleeding site. Endoscopy is the best initial diagnosis or diagnostic method and therapeutic procedure. Not the NG tube. So number 6 would be the angiography. So after failed endoscopy, the best next step so after failed endoscopy, then the best next step to control bleeding is angiography with a coil, what's called coil immobilization of the vessel. And the success rates for patients with acute peptic ulcer disease or peptic ulcer bleeding can reach up to 98%, with recurrent bleeding rates up to 20%. So for question number 6, we said angiography. And as we refer to the, if the answer was like an angi tube, for example, the nasogastric tube, it doesn't have any therapeutic role, doesn't do any kind of therapy, and it will not stop the bleeding either. So after the angiography, there was two orders were added, the BUN creatinine and CBC. And because why the BUN creatinine renal function test? Because patient who undergo any angiography because of the contrast media and its side effect on the kidneys, patient should have a serum creatinine level less than 1.5 and INR less than 1.5, and a platelet count greater than 50%, over 50%. So number 7, next step would be surgery, surgical procedure. So surgery is the next or the best next step in the management of complicated peptic ulcer disease, PUD, with persistent or massive recurrent GI bleeding. So additionally, in addition to this, if a patient presents with hemodynamic instability, hemodynamically unstable, despite all the vigorous resuscitation or patient develop shock with recurrent hemorrhage, then the surgery is indicated. And the surgical treatments or modalities for the PUD, it will include, they will sue or the oversewing of the artery with the truncal vagotomy. So there's complicated kind of procedures. They will suture, like for example, the artery with the truncal vagotomy or antrectomy with gastrojejunostomy, which is called Bell-Roth 2 procedure. Another name for the, for that long name, which is the antrectomy with the gastrojejunostomy. They do something, it's called also a Bell-Roth 2 procedure. So patient after the surgery will be sent to the ICU. So the number 7, we said the surgical procedure is the treatment. Now miscellaneous questions. This question, the answer would be to document the findings and continue to monitor the patient. The BUN can be elevated after a significant GI hemorrhage from the breakdown of blood proteins. So the protein breakdown release nitrogen that is less converted, and then it will be then converted to the urea. That's why that's anticipated and expected. WN to be 40. So that's due to the breakdown of blood proteins, which will result in nitrogen that will then be converted to urea. Now the experienced nurse is instructing the new nurse. The answer would be upper GI endoscopy with biopsy. The gastric mucosa can be visualized with an endoscope. The biopsy is possible to differentiate the peptic ulcer disease from gastric cancer and to obtain tissue specimens as well. So we can identify the H. pylori. And these are used or can be utilized to make definitive diagnosis of peptic ulcer disease. The urea breath test, that's only test for the presence of the H. pylori. The barium studies, they do not provide an opportunity for biopsy and H. pylori testing. So 2 tests that can, or diagnostic tests can test for the presence of the H. pylori, which are the urea breath test and the string test. Here we have a patient presents, so the patient's daughter presents the medication list illustrated. So these are the, the list of the, the meds the patient is currently taking. So as you review the list of the meds, which nursing action is most appropriate? So the answer would be 4. All medications listed here, they are used to treat liver cirrhosis and its complications of portal hypertension. Remember that esophageal varices as a complication from liver cirrhosis, because that esophageal varices results from as a complication from the portal hypertension and hepatic encephalopathy. So the Xifaxan or rifaximin, which is antibiotic, and also it's a trapped ammonia as well, take care of the excess of ammonia in the GI tract, and it will eradicate the flora, the bacteria, which is a source of ammonia as well, by a medication called rifaximin or Xifaxan. And in addition to another medication as a laxative, which is also has some effect, which is lactulose on the ammonia as well, to the, reduce the ammonia, because the liver is unable to convert the ammonia to less toxic form called ammonium. These 2 medications are used for treating hepatic encephalopathy. So we have to assess the client's neurologic status and measure the patient's abdominal girth. They are most important because the abdominal girth is a sign of fluid collection or fluid retained in the abdomen. Peritoneal, which is ascites, peritoneal fluid accumulation is the ascites, and as one of the mechanisms that would result from liver cirrhosis. Neurologic status assessment to assess for any behavioral changes or any the patient is also sometimes become combative and agitated, and that's because of the changes and change the mental status, and that's due to the what's called encephalopathy, which is due to the accumulation of the ammonia because of the liver cirrhosis. So number one, the antibiotics and acid-reducing medications, they are expected with the treatment of TUD. But propranolol, which is Inderal, would not be expected. Number two, which is that there is no any indication that the client has abdominal pain. And three, there is no indication that the client has an infectious condition that requires airborne precautions. So we'll continue with the colorectal cancer and the intestinal obstruction and cholecystitis in a different session. So I will stop here and we'll continue the rest of the content area or topics in a separate session. Will be recorded in a separate session.